before we start, I would like to introduce the Asian Head and Neck Network, and allow me to share the screen. Okay, so this is the logo for Asian Head and Neck Network. As you can see, the founder, it started off by Professor Putra from Thailand, Professor Marlinda from Indonesia, and Professor Alfredo Pontejos from the Philippines. And then after that, myself and also Professor Christopher Goh were invited to join the network. And the aims for this network is, number one, to have an academic and social collaboration. To have an academic and social collaboration among head and neck oncology fraternity in the Asian country. We would like to have also online meeting, conference during COVID's pandemic, and share knowledge among ourselves and exposure with other countries outside the Asian region. The first episode was in 22nd of May, 2020, on the management of head and neck cancer during COVID-19 pandemic. And then after that, we have the second episode on the 27th of July. As you can see, this is in conjunction with World Head and Neck Cancer Day 2020. Then our third episode in the 3rd of August, we have a guest speaker from Spain, Professor Javier. And then on the 4th episode on the 24th of September, and also this is in collaboration with the Academy of Head and Neck Oncology of the Philippines. As you can see, we have a guest speaker from United States, Professor Jatin Shah. The 5th episode was before this, it's on the 30th of October. And also we have a guest speaker, Professor Nibu from Japan. And today is our 6th episode, 4th December 2020. And we also have a guest speaker from Korea, Professor Hong, and also our Asian speaker, Dr. Professor Kitty. So the unique of this webinar is there will be a singing towards the end. So please stay back and enjoy the sing, and it's performed by our own head and neck surgeon in the region and also resident. And I can assure you they are very, very talented. So now I would like to introduce you the moderator for this session. It's my great honor to invite Professor Alfredo Pontejos. Is no stranger to our fraternity. He is a well-known figure of head and neck in this region. He is also a board member of the Philippine Board of Otolaryngology, Head and Neck Surgery. He is the past president for ASEAN Society of Head and Neck Oncology and board member of ASEAN ORL Head and Neck Society. So with great honor, I would like to pass the session to Professor Alfredo Pontejos. Professor Alfredo, the mic is yours. Maybe you can unmute yourself.
Yes, thank you very much, Professor Rajiv. As you all know, this is the 6th episode already, and we never realized that we are already having 6 of this. Now, the topic for this evening is all about the management of the salivary gland tumor, particularly the parotid. Now, management of the parotid gland would just be a walk in the park if not for the nerve that traverses the parotid itself, separating it from the superficial and the deep lobe. And so we have 2 experts that are going to discuss with us the diagnosis and management of this parotid and other salivary gland tumors. But before we start, we will have the pre-lecture poll. So could you show us the poll and please answer them? So all the participants, please answer this. So does fine needle biopsy change the course of your management for salivary gland mass? And number 2, what is the common malignancy in the submandibular gland? Okay, when you have answered, please submit. Okay, is everyone finished? Please submit your answers. So I think polling is still ongoing. Okay, so there you are. So number 1, does fine needle aspiration biopsy change the course of your management for salivary gland mass? 76% answered yes. 12% said it does not help much. FNAB never changes the plan in 11%. So these are the answers. So majority said yes, fine needle aspiration biopsy is necessary. Now on the second question, what is the most common malignancy in the submandibular gland? Squamous cell, 10%, adenocarcinoma, 17, adenoid cystic carcinoma in 23, and mucoepidermoid CA, 50%. So we'll see if your answers are correct when we have the discussion. So to start off, I would like to introduce to you our first speaker to talk about diagnosis and the evaluation of salivary gland tumors. He had postdoctoral fellowship in minimally invasive head and neck surgery in MD Anderson Cancer Center and was a global online fellow in head and neck surgery and oncology Memorial Sloan Kettering Cancer Center. And he is an associate professor, former head of the Department of Otorhinolaryngology, Prince Songkla University, Thailand, and currently the vice president of the Thai Society for Head and Neck Oncology. I would like to introduce now Professor Kitty Juntarapatana. Kitty, please.
Okay, thank you, Professor Alfredo. So I would like to thank you, the ASEAN webinar committee, to invite me to have the opportunity to share about the diagnosis and evaluation of the salivary gland tumor. Okay, so the outline of my talk today will include about the epidemiology, the clinical presentation, the imaging and fine needle aspiration, the common and uncommon entities of the salivary gland tumor. I would like to quickly review of the epidemiology that I think everyone might know about this. The chance of malignant in the parotid tumor is around 25%, and the submandibular gland is up to 50%, and the chance of the malignant of the minor salivary gland is around 80%. For the prevalence of the disease, so most of them is in the parotid gland is around 65%, and 27% arising in the minor salivary gland, and only 8% arise in the submandibular gland. For the risk factors of the salivary gland tumor is include the ionizing radiation, the EBV, nickel exposure, rubber industry, the current smoking and heavy alcohol is the risk for malignant in male. Talking about the clinical presentation, the most common presenting symptom of the salivary gland tumor is the asymptomatic lump in the parotid or in the submandibular area. The duration of the symptom is very important to give diagnosis. The shorter duration is suggestive to be the malignant tumor. However, the long-standing asymptomatic mass with recently rapid growth is suggestive to be the carcinoma X pleomorphic adenoma. And about the painful, it's just only less than 4% of the benign tumor have the painful, and only 10 to 50% of the malignant have the painful mass. If the patient comes up with the episodic swelling with pain and related to the salivary stimuli, is suggestive to be the ductal obstruction, for example, the stricture or the stone. If the patient comes with the bilateral or multiple mass, for example, in the parotid area, it's suggestive to be the Warden tumor. If the patient have complained about the facial twitching, there's some literature to suggest that it might be the facial nerve schwannoma. The clinical presentation that suggests malignant is, for example, it is about the local invasion. For example, the fixation to the skin, the less mobility, the facial nerve paralysis. For the facial nerve paralysis, is almost always malignant. It's very common in the adenoid cystic carcinoma and differentiate tumor and squamous cell carcinoma. And the facial nerve paralysis, it stands for the poor prognosis factor. And certainly the lymphadenopathy in the neck is the suggest sign of the malignant. For the nodal metastasis, overall of the salivary gland cancer have the nodal metastasis around 13 to 33%. Is common in squamous cell carcinoma, high-grade mucoepithelioid carcinoma, high-grade adenocarcinoma, and malignant mixed tumor. For the malignant of the submandibular gland, it might be very challenging to differentiate between the direct invasion of the lymph node and the actual lymphatic metastasis. The location at risk of the lymph node metastasis for the salivary gland tumor is it includes the tail of the parotid gland, the post-auricular area, the upper to the middle jugular areas. And for the more anterior tumor, the more anterior parotid tumor, the lymph node might be go to the perifacial and submandibular lymph nodes. One thing that very important in the clinical presentation is about how to differentiate the primary and metastasis squamous cell carcinoma to the parotid gland. The majority of them is metastasis from the cancer from the skin of the scalp or face or the external ear canal. So this picture demonstrates that the scalp in all area can drain to the periparotid or intraparotid lymph node and also the external ear canal. So we are ENT surgeons, so it is necessary to do the careful ear examination before you make the diagnosis for the parotid tumor. Another clinical presentation that interesting is about the accessory parotid tumor. So the accessory parotid tumor is arise along the course of the Stensen duct, and it presented with a mass in the soft tissue of the middle of the cheek. It might be located near the anterior border of the masseter and separate from the main body of the parotid gland. Yeah, this is you might come across with the accessory parotid tumor. And for the deep lobe of the deep lobe of the parotid tumor, only 10% of the parotid gland tumor arise in the deep lobe, and over 75% present as a typical parotid mass, and only less than 25% will present with the palatal or pharyngeal swelling, as this picture you can see. This is the deep lobe of the deep lobe tumor of the left parotid gland. It displays the lateral pharyngeal wall, and the CT scan show like this. For the minor salivary gland tumor, it's typically to be the submucosal mass. The consistency would be soft to firm or rubbery. So most benign tumor arising in oral cavity, and the other sides are usually malignant. Yeah. The next is about the imaging. The indication for imaging in the salivary gland tumor is, the first one is if you suspected the malignant, okay, is going to do the imaging, or you come across with the large tumor and you would like to know the extension, this is the indication. Or you are not sure about the deep lobe tumor, so just go imaging. And the minor salivary gland tumor that cannot, that you want to see the extension of the tumor. So the finding of the imaging that you would like to know after see the imaging is, the first is the intra or extra glandular lesion, how extent of the tumor, and how relationship of the tumor to the critical structure and the associated lymph node. And the last one is if you can draw the diagnosis for the imaging is very good. The MRI is the imaging of choice for the salivary gland tumor, especially in the parotid. MRI can show the extra parotid extension, can show the parapharyngeal involvement of the deep lobe parotid, and also the strength of the MRI is they can demonstrate the peritoneal invasion that is very common in adenocystic carcinoma. As you can see in this picture, this on the right side of the patient, this is a normal nerve right here. And on the left side of the patient, you can see this is the signs of the peritoneal invasion. This patient is the adenocystic carcinoma. MRI also can demonstrate the medullary bone involvement and intracranial extension. And what about the CT? We are more familiar with CT scan. And CT scan can demonstrate the tumor size. Very good for bony and skull-based involvement. They can demonstrate the deep lobe and the parapharyngeal space invasion, and for the lymph node metastasis and regional lymph node, the CT can well demonstrate it. What about the PET-CT? It might sound a little bit less useful for diagnose the salivary gland tumor. It just to help in some situation, for example, for the high-grade salivary gland cancer. If combine the PET with the CT, they provide more accurate than only CT alone. If you can see in the picture, this is the CT scan, and you can see this is a tumor of the right parotid gland. And if you combine with the PET, you can see the hyperactivity of this tumor means this tumor is very high grade. The next tool to diagnostic the salivary gland tumor that we might familiar with is the finite aspiration. It's very, very good for the benign tumor. You can see the accuracy in the pleomorphic carcinoma is up high to 95%. And for the Warthin tumor, the accuracy is more than 90%. It's very high, very good for the benign tumor. However, the sensitivity and specificity is decreased for the malignant. The sense to diagnose the malignant tumor is around 83%, but the spec to diagnose the malignant is 99%. However, there is some of debatable about the issue that finite aspiration is very necessary. There's a study that shows only 35% of the surgeon changed the clinical approach after doing the finite aspiration. So for those who say yes, the FNA changed the management, the reason is to avoid unnecessary surgery, for example, the lymphoma and inflammatory tumor. For the, it helps the surgeon to have a more conservative approach for the benign tumor and in the elderly and high surgical risk patient. And it also helps the clinician to have a better preoperative counseling to the patient about the nature of the tumor, the extent of the resection, the management of the facial nerve and the lymph node. And for those who say no, it's only in the situation that the patient have the clinically obvious small intrapollated tumor that the surgeon not change the plan, so they have to go surgery anyway. So to conclude, the 5 major indications for finite aspiration in salivary gland is to rule out the inflammatory lesions, to identify the systemic disease, for example, the reticuloendothelial tumor, to distinguish the primary and the metastasis carcinoma, and to evaluate the unresectable tumor in the poor surgical candidate. And the last one, to evaluate the lesion with low chance of a neoplasm, for example, in the children. Recently, there's interesting things coming from Milan, Italy. They not only have the good football team, AC Milan and Inter Milan, they have the Milan system for reporting salivary gland cytopathology. So if you see this table is look familiar with the thyroid finite aspiration report system. There are 6 categories: non-diagnostic, non-neoplastic, AUS, and neoplasm, suspicious for malignant, and malignant. The range of the risk of the malignancy is different, depend on the category that the cytology reported is around. So your number you can see in the screen right now, and they also have the usual management to guide the physician to manage the patient with each category. So after you take the history, you do the physical examination, imaging, and finite aspiration. You can draw the common differential diagnosis. So this might be, I think it's very common to know the prevalence of the benign and malignant tumor in salivary gland. In benign, the most common is the pleomorphic adenoma, following with Warthin tumor, lymphoepithelial lesion. And for the malignant, the most common is the mucoepidermoid carcinoma, the adenocystic carcinoma, and adenocarcinoma, so on. So that is the common things, but I would like to to share some of the uncommon entities that you might come across in the practice about the parotid tumor. The first case is she's the 50-year-old female. She had the left parotid swelling for 7 months. She also has the left facial twitching. When we do the examination in the ear, we see the ipsilateral external ear canal mass like this. And when we do the finite aspiration, she experienced as a sharp shooting pain when the needle piercing into the mass. And when we take her to do the MRI, so you can see this is the facial nerve origin mass with the internal cystic degeneration. This is very typical for the schwannoma in MRI findings. So this patient will be diagnosed as the intraparotid facial nerve schwannoma. The next uncommon entity is the inflammatory pseudotumor of parotid. This is the benign lymphoproliferative disorder, mimics tumor. CT scan can show a well-circumscribed inflammatory lesion with or without the central necrosis. The histopathology is composed of 4 elements. The first is histiocytes. The second is myofibroblast. The third is the plasma cell, and the last one is the lymphocytes. It's very difficult to diagnose in clinical, and it often made the diagnosis by exclusion. And the last uncommon entity is the HIV-associated parotid disease. If you don't know that patient is the HIV or not, sometimes you might not think about this situation. The common HIV-associated parotid disease is diffuse infiltrative lymphocytosis syndrome. And the next is the benign lymphoepithelial cyst like this. Typical is a bilateral and multiple cysts, but you might also come across with only one single cyst. It might be a presentation. For other situation is about the intraparotid lymphadenopathy, lymphoma, and Kaposi sarcoma. So in summary of the diagnosis and evaluation of the salivary gland tumor, complete history taking and physical examination is very essential. The proper imaging selection, the finite aspiration as a tool for clinical judgment. So then you can formulate a differential diagnosis and do not overlook the uncommon disease. So thank you.
Thank you very much. Thank you very much, Professor Kitty.
Thank you.
Thank you for the very informative lecture. And so we're going to proceed now with the second speaker. By the way, before that, if you have questions, just write your questions in the Q&A just below the screen, okay? So our next speaker is an associate professor and chairman and director of the Department of Otolaryngology, Head and Neck Surgery in Catholic Kwangdong University College of Medicine International, St. Mary's Hospital. He's also a very good musician, a violinist, in fact. So I'd like to introduce to you now our second speaker to discuss on the surgical management of tumors of the salivary glands, Professor Hyun Jung Hong. Professor Hong, please.
Hi, good evening, everyone. Thank you for your nice introduction for me, and it's a great honor to be here with you, everybody. It's almost
Could you
almost 300 people that get in. Okay, can you hear me?
Could you put your slide on the slideshow, please?
Yeah, sure, I will. Okay, can you see my slide here?
Yes.
Okay. And first, thank you and nice introduction. And I try to, before my talk, I would like to thank you, Alfredo and Petra Booth and Marinda here. It's a great honor to be here. Actually, my boss is Professor Choi has given me to this the keynote lectures, and in 2018 and 2019 in Bangkok, I show you guys at the peritectomy with Dr. Choi and Dr. Kim, and today's my talk about the surgery for the salivary gland. Especially, I try to focus on the peritectomy because of time limitation. As you know well, as Kitty says, the almost salivary gland has occurred in the parotid gland as for the parotid tumor. The surgery is one of the first option for the treatment. Actually, there are several groups in parotidectomy that we can divide it the superficial and total and radical parotidectomy. The radical parotidectomy means the sacrifice the facial lobe, but usually in parotid, one of the most common disease is Primo, is benign tumor. So we have to do familiar with this kind of fundamental. The procedure is the superficial parotidectomy. And then before the parotidectomy, you have to familiar with this the procedures in detail. And first head and neck preparation and skin incision and flap elevation and so on. And I would like to explain and show some my practice and parotidectomy. As Kitty says, preoperative evaluation and is included like this. And one more thing is you guys have to get the informed consent from the patient and their families and about procedures and risk of facial nerve injury and potentials for neck surgery, and expected sequelae or potential complications such as bleeding and late complication, the Frey syndrome. And one more thing is we can get the discrepancy between the preoperative cytology and the permanent pathology. And finally, the patient has the potential situation is advanced RT or the chemotherapy. And this kind of the risk of facial lobe injury and discrepancy of the final pathology is most important things. And I want to try to show my surgical skills in detail. And I would like to show one case is she has parotid tumor on the left side. It seems to be a primopioadenoma benign tumor. And head and neck preparation, and you can see the usual my incision design here, and usually I prepare the facelift incision like this, and there are several choice of the incision design, such as modified flare here and the Y incision, something like that. But I prepared this kind of modified facelift here, And after that, skin incision with cold scalpels. And then I would like to make the skin flap elevation to the zygomatic arch and mandible angle, and below the hyoid bone here, and subproximal muscle plane. You can see the vertical masseter fascia and ascending muscle here. And after that, you can see the tragal cartilage and the mastoid tip here. And the first step to the identification of the ES cartilage, you have to dissect here the superior to inferior like this. And then you can expose the soft tissue here and from the ES cartilage. And then you can go downside, and this is SCM muscle anterior border, and you can see the left side parted here. And I usually use with Bobby, the monopolar Bobby tips, use the delineation, the soft tissue from the anterior border of SCM muscle. And then you can see the middle of SCM anterior border, and you can see the great auricular branch here. Sometimes you can the posterior branch like this. And I try to preserve the posterior branch. And after that, you can identify the extrajugular vein, the below the great auricular lobe here. These two anatomic structures, extrajugular vein and great auricular lobe, is the competent, the superficial area landmark of parotid gland. And then you can ligate and dissect great auricular lobe for the wide exposure. And but sometimes you can preserve the branch of great auricular lobe. And next step is one of the most important thing is you can check. You can see the posteriorly of digestion muscle, underneath SCM muscle like this. This muscle is attached the digesting ridge of mastoid bone here, and the hyoid bone is to anterior side, and this is parotid gland is here. You can see the extrajugular vein here. And then for the clean and bloodless the surgical field, you have to identify the posterior auricular vein and artery here. This kind of blood structures goes to the posterior, the direction from the extracarotid artery and the vein plexus. You can see this artery during the parotidectomy, before the identified facial lobe trunk. For the clean surgery and bloodless field, you have to find this posterior artery here in this area, above the digestive muscle posteriorly here. And after that, you can see the posteriorly here and auricular cartilage, and just between the structures, you can identify the facial lobe trunk here. These two anatomic structures most important structures for the parotidectomy. Usually we can do the trace, the facial lobe. Whenever I do the periodectomy, I'd like to identify this kind of 2 or 3 constant landmarks, and sometimes especially it's a lesion case or the huge tumor cases, you have to do the mastoid drilling. Sometimes you have to do retrograde dissection for after identify the marginal or buccal or zygomatic branches. And usually I use these 2 branches for the retrograde dissection. But in usual setting and for the superficial periodectomy, and you have to do familiar with these anatomic structures. And after that, and you can do any kind of surgery like this in the benign tumor. For the tracing, the facial lobe like this, you can do the mosquitoes and something like that. And after that, you can do Thai or ligation with harmonic or something like that. And usually I do the periodectomy to the superior to inferior for the preservation of the facial lobe. And after that, you can see the stentous just is the middle of the periodectomy. And then you can ligate and parotid tissue out here. And after tumor lesion wall, you can see the whole branch of the facial lobe here, the marginal and buccal and something, and temporal facial branch here. And you can see another case here is the usual the dissection procedures. And then, so another guy has the whole body tattoos. He seems to be the gangster from South Korea. Who knows? Anyway, he has a dimnode tumor like this. I can do the periodectomy without any injury at the facial lobe. And the one more thing is it's a little bit tricky case in the dimnode tumor here. And after identify the facial lobe trunk, and then you can handle, you have to take care of the facial lobe trunk injury, and like this. And you can see the whole, the consistent anatomic structures, the ASEAN muscle, posterior belly, EHA, cartilage here, and facial lobe trunk, temporal facial, and cervical facial branch, marginal branch here. Okay, this is a total periodectomy case. And you can see the postoperative result, and this, like this, and I prefer that this kind of the modified facelift incision like this for the periodectomy. There is no facial lobe injury, and he has satisfied, and even he has the adenoid cystic carcinoma, and everybody is satisfied by its invisible scars and wonderful post-operative scar outcomes. And then I moved right to the short the video clips or something, and usually since 2004 and 5, and I've moved an endoscopic surgery like this for the neck surgery, and you can see the for the thyroidectomy and upper neck surgery, use the endoscope or robotic surgery for the after making walking space, and you can do the whole kind of surgery to lateral to medial dissection, and even neck dissection like this, and and this kind of procedures is applied to the parodectomy procedures. And this is in neck dissection cases. She has the parotid cancer with neck metastasis is conventional. The procedures in 2020 like that, but I would like to show another the similar cases. She has 48 women and with parotid with neck metastasis. Probably it's malignant tumor, and I'd like to total parodectomy and the endoscopic neck dissection like this. And after that, the final report is mucoid carcinoma, high-grade tumor, and just only one neck metastasis. And I would like to show another video clips from Dr. Go, and Dr. Go. Oh, oops. Dr. Go has sent me some videos. And can you see this video, right? Okay, these days, one of the most innovative technology is robotic surgery. And he tried to focus on the robotic surgery with neck and thyroid, even parotid tumors. And this is Dr. Go's cases. And she is 23 woman and with parotid tumor, mucoid carcinoma. And you can see the left side parotid here. The robot parodectomy is same procedures, just only use a robotic system. But you can see the 10 magnified highlighting and crystal clear view on the console. You can do the same procedures.
All right.
Good. All right.
Good.
From the start, I tried to explain again. And she is 23 woman, years old female, and with the mucoid carcinoma here. And this is left side. You can see the wonderful video clips is on the magnified view. Oh, sorry. Oh, so sorry. And then you can see the cartilage here, and you can see the wonderful dissection without bleeding, the clear view, the lower system. You can see the facial lobe trunk here.
Yeah, facial nerve, yeah.
Yeah, right. And usually goes to use the facial monitoring like this. And you can see the EAC cartilage. And then you can see the postoperative of digestive muscle. And then dissect the facial lobe, the usual procedures, and with the robotic system like this. Yeah. If you are familiar with the conventional parodectomy procedure, you can do this kind of robotic surgery like that, and then just only this robotic system as a wonderful magnified view like this. And then she has certified her the postoperative and another video here, but I would like to move. Can you see the PPT here?
Yeah.
Okay. Finally, I would like to move the and neck treatment, especially in patients with neck metastasis, we can consider the neck dissection. If the patient has the multi-level neck metastasis, we have to comprehensive neck dissection we have to do. But if you have no evidence of neck metastasis, probably we can do consider the observation or the after getting the final diagnosis, and after the add the RT, post-op RT, and this is the post-operative radiation therapy indication here, and in the high-grade cases, and high stage or positive margin or the ECS, something like that. And more, the systemic chemotherapy is in rare cases for the polyepithelial setting, unresectable on the recurrent or distant metastasis like that. And follow-up protocol is here is the same in head and neck cancer. And for the salivary gland tumor surgery is the mainstream is paroidectomy. So my prefer the incision is modified facelift. You can do with this incision all kind of surgery, and in paroidectomy surgery is you have to do familiar with the around the anatomy, and after that you can do fine dissection for the facial preservation, and then you can familiar with the paroidectomy. Even more, in Korea is endoscope and robotic surgery is popular ever than before, and then you can, if you are interested in, please join our program in Korea. And thank you so much. Yeah, time's up.
Okay, so thank you very much, Professor Hong.
Yeah, thank you.
Thank you. And so it was a very educational and very informative lecture. So we would go now to our panelists. We have 3 panelists, one from Malaysia, one from the Philippines, and one from Indonesia. So I'd like to start with our first panelist, Professor Primo Harsa Putra. He's a clinical professor in otolaryngology, head and neck surgery in KPJ Healthcare University College, past president of the Malaysian Society of Otolaryngologists and Head and Neck Surgeons. So, Prima, could you give your comments on the presentation and your thoughts on this topic? Go ahead, Prima.
So, good evening, everyone. So, first of all, I would like to thank the
committee. Could you increase your audio? Increase your audio, please.
Okay, thank you, Prof. Alfredo. So, good evening, everyone. So, first of all, I would like to thank the organizing committee for inviting me to take part in the webinar. So, I just want to highlight, or comment on the first, this one, on the fine needle aspiration cytology or biopsy. I agree with Prof. Kitty, the need of the fine needle aspiration cytology in the, pre-operative diagnosis. So even though this is not everybody agree, because some of us do proceed with the parotid surgery without doing fine needle aspiration cytology, based on the most common diagnosis for parotid is a pleomorphic adenoma. But personally, I still do a fine needle aspiration cytology for every parotid surgery, because the advantage is we can differentiate whether it is a benign or malignant. And also we can pre-operatively counseling the patient if it is, for example, is a malignant. So we can at least give a prediction or risk, the risk of the facial nerve is there, because intraoperatively when we open up and the tumor is already erode or already involving the nerve, we might sacrifice the nerve. So we can actually discuss or explain to the patient the risk of the facial nerve. And also the other thing is when we know that it's a malignant and we know that it's a high grade, so we can also counseling patient about the neck dissection. The neck dissection in which we need to open the neck during the parotid surgery. And also if it's involved, we can know the pre-operative diagnosis from the FNSC. We can also predict, for example, in mucoepidermal CA, so post-operatively patient might need a post-op radiotherapy. And also, I want to also give my comment on the management of neck, okay? Because I think this is a very common question being asked by our trainee, how to manage the neck, okay? So in terms of the neck management, because as we know that only the risk of occult metastasis in parotid is not very very high. So it's only about 20%. Okay, so if the patient presented with clinically positive neck in a malignant parotid, so the treatment in this patient, it might require a comprehensive or modified neck dissection. Is in clinical positive neck. Then how about the clinically negative neck, which is not routinely advocated for all parotid cancer? No, I mean in terms of the elective neck dissection. So what are the indication for elective neck dissection in clinically negative neck? So the most common that we have been taught is all depend on the grade of the tumor and also the types of the tumor. Why this thing happen? Because there is a lot of diversity in the parotid malignancy. And other tumor that require elective neck dissection is adenocarcinoma, high-grade adenocarcinoma, ACC, and polydifferentiated carcinoma, plus high-stage grade 3 and 4 parotid malignancy. And what type of neck dissection in the clinically negative neck, like so it's most probably the most common one is the selective neck dissection. Okay, thank you.
All right, thank you very much, Primo, for your comments. So we'll now have Professor Jeanette Matsuo. She's the head of the Division of Head and Neck Surgery at the University of the Philippines, Department of Otolaryngology, Philippine General Hospital, Associate Professor of the University, and a member of the Executive Committee of the ASEAN Head and Neck Society of Head and Neck Oncology. So Jen, could you give your reaction?
Okay. Good evening, everyone. First of all, I'd like to thank the organizers of the ASEAN Network for the invitation. Because I look forward to the questions posted by our participants, I'll keep my reactions very short. For Professor Kitty's lecture, it was a very comprehensive lecture, very informative, especially for the younger members of the audience, for the residents in training. I also do FNA for most of my salivary gland tumors. I have some questions though. Do you image all salivary gland tumors, regardless of size? And also in cases of inconclusive FNAs, what is your opinion about doing a core needle biopsy for salivary gland tumors. But aside from those questions, Professor Kitty has covered everything in the diagnostic approach for salivary gland tumors. That's what I think. Regarding Professor Hong's lecture on the surgical management, it was very comprehensive. Our hospital just recently acquired a robot also, so we are in the process of sending members of our faculty for training. And South Korea is one of the training centers that we have been eyeing to go to for training for robotic surgery for various head and neck procedures. So the informed consent slide is very, very good because especially the younger residents, they fail to inform the patients of the numbness of the earlobe and the depression deformity that goes after doing a parotid surgery. So there will be questions. I saw some questions posted in the Q&A box about how to address this, especially the depression deformity after the parotidectomy procedure. So I'll keep my reactions up to this point only, so we can answer all of the questions being posted. Thank you.
Thank you. Thank you very much, Jeanette, for your comments. And the last panelist is Dr. Sukri Rahman, an otolaryngologist and consultant in head and neck surgery and oncology at the Faculty of Medicine, Dallas University. And he's also a consultant otolaryngology at Dr. Jamil General Hospital, Padang, Indonesia. So Dr. Sukri Rahman, please.
Okay. Thank you very much, Professor Alfredo, for your kind introduction. Just some comment from me that I think have been already mentioned in the lectures and also by the previous panelists. Primary tumor of the parotid gland are the largest proportion of the salivary gland tumor. Tumor in the parotid gland mostly benign. The presence of the local inpatient, cervical node, and facial nerve involvement are strong predictor of malignancy, just Dr. Kitty lectures. Imaging are essential to accurately delineate the location and extent of the tumor. CT and MRI are equally satisfactory in evaluation relationship of the tumor to the adjacent structures. Open incision biopsy is not recommended for the parotid and submandibular gland due to the potential risk of tumor seeding and injury to the facial nerve and its branches. Finite aspiration biopsy provide an insight into the initial diagnosis of salivary gland tumor. The prognosis of salivary gland tumor is associated with the histological grade in addition to the stage of the tumor. Thus, Dr. Harsa say, nodal involvement also an important negative prognostic factor. Regional lymphatic spread of this cancer also varies according to the histology and the size of the primary tumor. Low-grade tumor rarely metastasize to the regional and have an excellent prognosis. On the other hand, high-grade tumor have aggressive behavior with high risk of regional distant metastasis and associated with a poor prognosis. So the size of the primary tumor and its histologic grade are very important factors that influence and should always be taken in consideration when determining treatment option. Low-grade and low-state malignant tumor confined to the superficial lobe of the parotid gland are effective treats with a superficial parotidectomy. Surgery alone in this clinical setting is adequate treatment. On the other hand, high-grade and high-stage tumor is the bigger tumor, more than 4 centimeters tumor, may require a total parotidectomy or even extended radical parotidectomy without neck dissection, and sometimes with postoperative radiation. And I just comment to the second lectures that we know the primary goal of the treatment of the patient with a benign and malignant tumor of the salivary gland is total removal of the tumor, but preservation, the function, particularly the facial nerve, and produce a pleasing aesthetic is an important goal in the surgery for parotid and submandibular gland tumor. I don't have experience in the robotic surgery, and also just to answer the question in the can and answer. And also I have no experience using a nerve monitoring during a surgery. But I believe nerve monitoring will be helpful in revision parotidectomy or at recurrent tumor for identification and protection of the basal nerve in scar tissue, because it's sometimes difficult to differentiate it. It's the nerve and the scar tissue. So that's my comment for discussion in this evening. Thank you very much.
Thank you very much, Sukri. And so all the panelists and the speakers, please turn on your videos. And we will have the questions. Those who have questions, please type them in the Q&A. Okay, there's one question here. Well, a comment actually, and a question. Professor Hong, beautiful hairline scar. Would you do a flap to replace the sunken operative site and as prevention against Frey's syndrome? Professor Hong?
Yeah, I try to typing in the answer the slide, and I'd like to explain. In my cases, in sometimes I try to for the rotation flap with ASEAN. ASEAN muscle flap is more the competent the flap for the sunken down the defect. And this times we try to the artificial dummies in which is the Korean company is make some.
Sorry, what is this? What is this?
Artificial dummies, such as Megadon.
Okay.
So for the detect the
so
cardiac spaces.
Yeah,
right. In some cases, not every cases.
Yeah. Do you think the flap, whatever flap you put in, can prevent Frey syndrome?
For the prevention, the Frey syndromes and the every surgeons have to do the make a skin flap more thicker.
Yes.
And then you have to do the skin flap above in the subproximal muscle and above the vertical muscular fascia plane with the fatty tissue.
That's right.
It will make helpful for the prevention.
Anyone else who would like to give a comment from the panelists or Kitty?
Yes, I would like to respond about the questions of the to perform the CT MRI routinely. So for personally, I don't routinely perform the CT or MRI in the benign and small tumor, especially in the tail of the parotid tumor that I think the imaging might not change my practice. So that is only that I don't do it routinely. So, and another comment or questions from Professor Masur about the coronidal aspiration. When the finite aspiration comes up with the inconclusive. For me, I think if the finite aspiration come up with the inconclusive, I would go to at least superficial parotidectomy. I don't prefer the coronidal aspiration because it's the large bore needle might resulted in the seeding from the needle tract. So I would go to open surgery.
Okay. Okay, we don't have any more questions, but I would like to ask the panelists, the group, about the role of extracapsular dissection. I mean, we were taught that we have to do superficial parotidectomy, partial superficial parotidectomy. But could you comment on extracapsular dissection, particularly on benign tumors? Of course, if it's malignant, obviously we have to be more radical. But for benign tumors, of which 80% of our tumors are benign, particularly the pleomorphic adenoma, comment on the ECD or extracapsular dissection. Anyone? Anyone from the panelists would like to give a comment? If they have experience with extracapsular dissection?
Can I have answer?
Yes.
In my opinion, if the tumor is small, tumor is located in the lower, and you can do the adequate parotidectomy is enough. And but the usually is parotid tumor has the pseudopore in the surround area, especially in the pleomorphic adenoma. And so I would like to do in all cases is adequate sufficient parotidectomy with the sufficient margin. So I don't like the extracapsular dissection, especially in benign tumor and also the malignant tumor. I prefer the more the adequate parotidectomy. I call the adequate parotidectomy with the sufficient margin, more than, if possible, more than 5 millimeter or 1 centimeter. And it will be helpful for the prevention is the recurrence after in 10 years and more than 20 years later. And fortunately, I have no recurrence cases yet, but who knows? As the benign tumor is slow growing, and yeah, I have the several the recurrence malignancy cases, and after the 10 years later, and in my cases, and so with better to do the adequate parotidectomy will be helpful for the recurrence, I think.
Okay, yes. Of course, for the audience, of course, extracapsular dissection is not enucleation. Enucleation is just like removing the tumor itself. But extracapsular would mean you have also a margin, but you don't remove all the superficial parotid. Of course, this is very controversial. There are some proponents of this. And of course, some would still stick to the standard superficial parotidectomy. So, we have other questions now.
Have some more comments.
Yes.
Yeah. Right now, I think there is a lot of variation of the parotidectomy. We have partial, superficial parotidectomy. We have ECD, as you said, and
extracapsular,
yeah, and some of the literature say about the enucleation, but for me, I think it's an issue of the facial nerve identification. If we do the facial nerve identification as the standard parotidectomy, and we remove some of the part of the superficial lobe of the parotid, so that is the partial superficial parotidectomy. That would be the safe way to do. But for the ECD, I think there is no facial nerve trunk identification as the standard parotidectomy. So it's quite too risky to do facial nerve injury. But in the literature, they reported very good result.
Yes.
In the ECD,
in some articles. Yes.
Exactly, for the head neck surgeon to do less, but I think we have to practice a lot to do the ECD very well. Okay.
Yeah, I think you have to be very good with superficial first before you start to think about possibility of extracapsular dissection. Yes, very well said, Kitty. We have other questions now. Here, how often do you see Frey's syndrome as a complication in your practice? Anyone? How often do you see Frey's syndrome as a complication in your practice? Anyone who would like to answer? Primo? How often do you see Frey's syndrome?
I never seen even one case for post-Frey syndrome.
Okay.
I mean, it's very rare.
What about Dr. Jen Matsuo?
Yes, I've seen patients 10 years, 15 years out, and I've never seen Frey syndrome.
Oh, yeah?
Yes,
Okay.
I specifically asked about gustatory sweating, but
Yeah.
they report nothing, no.
Sukri here?
Yes, I had once the patient with a Frey syndrome after surgery and also breast bite syndrome after parapharyngeal tumor removal.
Right, yeah.
Only once.
Okay.
With Frey syndrome, it's a parotidectomy, superficial parotidectomy, and one with a breast bite syndrome after removal of the parapharyngeal tumor.
Okay, Professor Hong?
Actually, it's in my patient list is I have experienced just on 2 or 3 cases.
Yeah.
In more than 500 cases, but I have several experiences from the patient from the another hospital, and so for the Frey syndrome patient, and I have to do the test, minor iodine test, and I do the injection, the Botox injection these days. Yeah, right.
That's right. Okay. Professor Kitty, would you want to answer this question too?
Yeah, not often for the Frey syndrome. Is quite hardly to see after for me. I think is quite rare.
Wow. Okay. All right. So the next question is, when would you do or intervene for reanimation procedure if sacrificed due to tumor, and in other cases repaired intra-op but no sign of improvement? Okay, I'll repeat the question. When would you do or intervene for reanimation procedure if the nerve is sacrificed due to tumor and in other cases repaired intra-op but no sign of improvement? So meaning, when do you do reanimation procedures in a patient with failed nerve repair, or in patients where you did have to sacrifice the facial nerve? Anyone? Anyone who would like to answer that? So when would you do reanimation? Anyone who does reanimation?
Actually, so before the sacrifice, the facial nerve,
Yeah.
we have to do to get the sufficient the proper information about the tumor before the surgery, and if possible, if the possibilities happen, we have to prepare the immediate the facial reconstruction, I think. But if it is not possible, I try to do as soon as possible for the reconstruction and the reanimation surgery. with the Shura or the great auricular hypoglob, like that. I do. Mm.
Okay, another question for Professor Kitty. Thank you for the clarification. However, if FNAC reveals lymphoproliferative lesion with inadequate sample for staining, is superficial parotidectomy still recommended as a choice of option compared to core biopsy?
Yeah, it's yeah, very good question too. It's very challenging. But I think the finite aspiration itself, it has a lot of limited of them. For example, the cytopathologist that in your institute that how often that they read the cyto of the carotid or the salivary gland, that is very important. And I think if it come up with the lymphoproliferative lesion, I think this kind of thing might be wait for we can wait and see how progress of the lesion instead of the going to do the surgery. Yeah, for me.
Yeah. All right. There's another. Any limits to robotic parotidectomy versus conventional method, Professor Hong?
Yeah. Actually, it's quite difficult answer and difficult question and answer. Is if you have the robotic systems, you can try to the robotic the surgery in face, parotid and neck and thyroid, but I think there is no the limitation and personal limitation and economic limitation, but just the only the clinical setting or the personal and patient preference or the economic status and something like that. And yeah. And Dr. Go and I, in my opinion, some days we can do all kind of surgery with the robotic and computer systems without any intervention of the direct surgery. It's just like a movie. Some days in 20 or 15 years later. It's, I hope so someday. Yeah, right. There is no limitation and indication. Yeah.
Yep. Thank you. So the next question is, does postoperative radiotherapy play a role in advanced stage salivary gland tumors? Anyone who wants to give an answer?
Yes, I think it's depend on the stage of the tumor. Is the pathology of the tumor, the radiology, the pathology, in the high grade tumor, and also in the heat tumor more than 4 centimeters, and in the negative, in the positive neck will or indication for the radiation after surgery, I think.
Okay. Any comment on radiotherapy in post-op adenoid cystic carcinoma? Anyone? Does it have any advantage? Anyone would like to answer?
Professor Pantejos, I'd like to say something about that. I would recommend post-operative RT for adenoid cystics, especially for salivary gland tumors in sites such as the maxilla, where you do not really have, and when your histopathology result comes out as close margins, then well, even with good margins, but if it's in an area that's where your margins are not really very, you think your margins are not really adequate, then I would recommend post-operative radiation.
Okay.
Almost all.
Yes. All right. Question for maybe for Professor Hong here. Thank you for a wonderful presentation regarding the Frey syndrome. How long do we need to follow up after Botox injection? So when do you do Botox injection? When you have Frey syndrome? Professor Hong, can you do this immediately or you wait?
Yeah, I've seen the question.
Yes.
Yes, from Iman Pradana. Yeah, right. And so, in my cases, for the patient with Frey syndromes, I try to explain the reason why they happen, and after that, I try to observe and the close follow for a while, and in 3 months, and after that, and I try to get some information or some video from the smartphone and from the patient and the syndrome, Frey syndrome, and then after that, after consultation, and we try to make a decision for the timing of the Botox injections. And then because of the Botox injection is high, a little bit expensive in Korea, and after that, and the next question is the best time to give Botox injection. We're right, and I think is there is no exact time, the best time to give the Botox injections, but it would be helpful for the decrease the symptoms for the patient. It will be the best time, yeah. Okay, I think.
Okay.
Is it okay?
Yeah. I think then the next question has been answered. This is the extra capsular, the one from anonymous attendee. Anyway, from Koirul Anam, for biphasic salivary gland malignancies such as epithelial, mucoepithelial carcinoma, it is often reported recurred after the resection. What should be considered to prevent recurrence for this disease? Is there a role for RT or CT or chemotherapy for these tumors? Comments? I think it's talking more about high-grade mucoepidermal.
High-grade mucoep, yes.
Yes.
Yes, for high-grade mucoepidermoid carcinoma, we usually recommend adjuvant radiation. But chemotherapy, very rare, almost none at all, except for disseminated disease. But for local control, it would be just adjuvant radiation for high-grade salivary gland tumors.
I agreed, yeah.
Okay, yes, all right. Now, we have now a lot of questions. The modified facelift incision yield very good cosmetic outcome. However, is there any situation where this incision is not suitable and you need to use the modified Blair incision?
Yeah, thank you for nice questions. Actually, so I had no experience the conversion to the modified Blair or the anterior incision, and if you make a sufficient surgical the space to the anterior face or the lower anterior neck, the elevate the skin flaps, you can do any kind of the the surgery, especially in parotid gland.
Okay, thank you. And there's another question here for parotid malignancies with skin involvement. What are your options for reconstruction? Labs. Anyone?
Yeah, I will.
Okay.
I think the cutaneous defect after removing of the tumor involved of the facial skin, I think the regional flap that can take place, this is SAI or supraclavicular flap. It can very good color matching and easily to move from the supraclavicular area and to cover the parotid area.
Okay, right. So any difference in selective node dissection level for deep versus superficial lobe tumors? Comment?
As I told you, the evidence, there are evidence of the neck metastasis, we have to consider the comprehensive neck dissection. But these days, we have to move the super selective neck dissection for the neck metastasis. You can do the level 1B and 2 and 3 up to 5 is the essential area. And then if there are evidence of the row 4 or row 5, you have to do a whole comprehensive neck dissection. And it's my practice rule.
Yeah, okay. So we're down to last two questions. If the FNAC is inconclusive at the time of surgery, and there is a suspicion for malignancy, do you wait for the proper histology confirmation before doing a more aggressive operation when no frozen section is available? Did you get the question? So if the FNAC is inconclusive, but there is suspicion for malignancy and you don't have a frozen section, do you wait for a proper biopsy report, final histopathologic report, before you do a more aggressive operation? Anyone?
Actually, in my opinions, I don't like the intraoperative, the frozen section. Is if there is no need to the frozen section for the parotidectomy, and as I told you, in every case, I try to advocate parotidectomy for even in malignancy cases, and after that, we got the final report about the final pathology. If it would be the malignancy cases, you can do the review the patient information and the pathology in detail. If is there any adverse features and such as perineum invasion or the high-grade malignancy, we have to add to the postoperative radiotherapy, in my opinion.
Yeah, I agree with Dr. Hong. The intraoperative frozen section for the salivary gland tumor is very challenging. You have to have the experienced pathologists that often doing the frozen section of the salivary gland. And I think if the question, is there any suggestion for the malignant, I think I'm gonna go on the surgery with the to have the safety margin with the normal cuff of tissue around the tumor. That would be more beneficial than doing the frozen section.
Mm-hmm. Okay, we have here one question. Oh, we have more. Do you still preserve the facial nerve in cases of advanced stages of salivary gland malignancy? Anyone? For advanced stage malignancy, do you preserve the facial nerve still?
Yes, I will give a response to Professor Alfredo. That said, I still preserve the facial nerve regardless the stage of the tumor. We preserve the facial nerve as long as the tumor not encase the facial nerve. So it's not depend on the advanced stage of the tumor. As long as it can preserve, I try to preserve the facial nerve.
Okay.
I also try to preserve the facial nerve in this type of cases, unless this tumor is already directly infiltrated the nerve or inseparable from the tumor.
Okay. All right. Thank you. So we have the last two questions. Professor Kitty, how was the inflammatory pseudotumor of the parotid case that you presented just now treated? And which treatment modality did you do? From Mark Paul.
Okay. For me, in my practice, I never seen the inflammatory pseudotumor of parotid. Just the some of the literature said about this mimic the tumor, and we have to be careful to have the diagnosis. And I just quick research the treatment of the inflammatory pseudotumor is there's wide range. ASEAN would be an option, and some propose about the radiotherapy, chemotherapy, or steroids. That is the whole bunch of the treatment options for the patient, but I don't have
I don't think so.
Yeah, going to deep in the result of each treatment.
Okay, so I think that's about it. All right, so I would like to thank all our speakers, Professor Kitty, Professor Hong, and our panelists, Dr. Primo Harsa, Putra, and Professor Janet Matsuo, and Professor Sukri Raman for your presentations and for answering all the questions. I think this has been a very informative and very, very good sharing of discussions. So I would like to, there will be an evaluation form that will be given to you. Please answer them so we could have your feedback, okay? All right, just click on to the QR, just, okay, and
can I?
give us your feedback. Yes, everyone can, yeah.
Oh, beautiful.
Okay. Yeah, a few more seconds, and then please answer them so we will have, we will know what your comments are, so we can improve on these webinars. And the last part, I would like to introduce Marlinda Tam, Professor Marlinda Tam, a very good friend, a doctor, a former president of the ASNO, and a professor at University of Indonesia, Cipto Mancukuso Hospital. So Marlinda, introduce the next part of the program.
Thank you, Prof. Alfredo, for the very nice introductions, and always best friends of us. And as a typical Asian Head and Neck Network webinar, we always close with a song. It has been already 10 months. We have a new normal, and that changed our social life. Many countries around the world adopted unprecedented restrictions to isolate their populations in their homes and from others, popularly termed quarantine or social distancing. It has also affected our work and life as head and neck surgeons. In these situations, we always try to strengthen our spirit and motivations by singing "Stand By Me," which has a meaning: the strongest people make time to help others, even if they are struggling with their own. Let us keep supporting each other. Enjoy the song.
When the night has gone and the land is dark and the moon is the only light we'll see.
No, I won't be afraid. No, I won't be afraid. Just as long as you stand by me. So darling, darling, stand by me. Oh, stand by me. Oh, oh, stand by me. Stand by me.
If the sky that we look upon should tumble and fall,
All the mountains should crumble to the sea.
I will cry, I will cry. I won't shed a tear. Just as long as you stand by me. And darling, darling, stand by me. Oh, stand by me. Oh, stand by me. Stand by me. Stand by me. Darling, darling, stand by me. Oh, stand by me. Oh, stand by me. 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 Whenever you have trouble, won't you stand by me? Oh, stand by me. Oh, stand by me. Stand by me. Stand by me. Stand by me. Oh, stand by me. Whenever you have trouble, stand by me.
and the land is dark, and the moon is the only light we'll see. No, I won't be afraid. Oh, I won't be afraid. you stand by me. Won't you stand by me? Oh, stand by me. Stand by me. Stand by me. Stand by me.
Finally, we came into the end of this 6th Asian Head and Neck Network webinar, which the last webinar we held for 2020. We will have the first one in 2021 on February with the topics of nasopharyngeal carcinoma. We would like to thank our remarkable speakers, Dr. Kitty Jatanarapatana from Thailand, and also Professor Yoon Jun from Korea. And also respected panelists, Professor Primo Harsa Putra from Malaysia, Dr. Janet Matsuo from Philippines, Dr. Suri Rahman from Indonesia, and also the moderator, Professor Alfredo Pontejos, and the chairman, Professor Muhammad Razif, for bringing out this topic, core values, that we had good discussions. And also for Johnson & Johnson's that have been supporting us since the beginning of the webinar. And also, I would like to thank Patrafood that designs music and also make combinations with the traditional music from the Thailand, which really make a good harmony. On behalf of the organizing committee, Patrafood Patanasap, Professor Alfredo, Professor Muhammad Razif, Professor Christopher Goh was not here, and also myself, I would like to wish all of you early Merry Christmas and a new prosperous 2021. We hope the conditions will be better and we can meet face to face as soon as possible. The message is keep healthy and keep up the good faith. And don't forget to open your camera because we would like to have a group pictures. Thank you and good night.